Good afternoon, and welcome to our third webcast on global budgeting for hospital services. This one is Global Budgets in Your Neighborhood. I'm David Chin, and I'm a distinguished scholar at the School of Public Health and also Director of Executive Education for Value-Based Healthcare at the school. Joining me this afternoon are two colleagues from the school. To my left is Joshua Sharfstein. He's a professor and Associate Dean for Practice and Training. And he was also formerly the Secretary of Health in Maryland, where he was one of the key leaders who led the design of the waiver for global budget and its negotiations with CMS and its first year of implementation. Parenthetically, he's co-author of a November 12th New England Journal article on the results of the first year, and I can say that they've been very successful. To his left is Darrell Gaskin. He's Associate Professor and also Deputy Director for our Center for Health Disparities Solutions at Hopkins. And he has made a career looking at access for vulnerable populations, as well as he'll be our resident skeptic this morning in terms of raising issues in your neighborhood in terms of implementing this global budget. Before we begin, I'd like to say a word of thanks to the Maryland Hospital Association and also to the American Hospital Association for collaboration to make this series of webcasts possible. As I mentioned at the outset, this is the third in a series of webcasts on global budgeting. And the global budgeting, as you might recall from the first episode, is a new way of paying hospitals so that they are no longer rewarded for volume. Instead, they're rewarded for preventable admissions to the hospital. The first webcast went over that overview. The second webcast relayed a case study of a hospital that had 4 years of experience under global budget and highlighted some innovative ways in which they used the savings associated with in the global budget program to invest in new programs like training police officers to be frontline caregivers, as well as utilizing pharmacists in innovative ways. Today's webcast is going to focus on global budgets in your neighborhood, in areas where there might be a lot of fee-for-service. There isn't a state waiver yet. The fourth webcast, which will be next week, will focus on global budgeting in the care continuum. And finally, our last and final webcast will focus on the federal perspective. So in terms of the format for today, we're going to have about 30 minutes of presentation via PowerPoint from Josh and Darrell, and then followed by Q&A. And you can send questions at any time to globalbudget@jhu.edu. That's globalbudget@jhu.edu, and those questions will come into the iPad right here, and I'll be able to direct them to both Josh and to Darrell during the webcast. So over to you, Josh.
Great. Thanks so much, and thanks, David, for hosting this series. I've heard a lot of good feedback about it, and it's exciting to be part of one of the webcasts. And thanks to you, Professor Gaskin, for joining us today also. It's fun.
Well, I'm looking forward to talking about this. I think it's an exciting issue and certainly something in which the nation should be interested in learning about.
Great. So we will start with some slides, if that's okay, and maybe have some discussion around them. If we can pull them up. The topic is hospital global budgeting in your neighborhood. So not to belabor this point, but there are some advantages to global budgeting. To think if you're working for a hospital or you live near a hospital or you've heard of a hospital, you may wonder whether this is a good idea in your area. And why would it be a good idea? Well, there are a few reasons. One is that it provides revenue stability without the requirement that hospitals keep the beds filled. And some people think of the traditional way of paying for hospitals as still sort of like a hotel. You need to have bodies in the beds for the hotel to be paid, and hospitals are largely still paid like that. And to switch away from that is scary for hospitals if they're going to be losing revenue. If they're going to be out trying to prevent admissions and suddenly they're not getting paid anymore, that's a very scary and probably impossible thing to do. But what a global budget does is it says to a hospital, you will have you'll know your revenue, and you can work on preventing admissions without the fear of losing that revenue. And so the second incentive, the second advantage is that it gives you a strong incentive to reduce preventable admissions. I once gave grand rounds to Johns Hopkins Medicine a while ago, and I said to the residents who were falling asleep in the front row, trying to keep them awake,
Right.
you know, you guys round on your patients and you think about all the things that your patients may have, and what can be done to treat them. What if you also talked about what could be done to help them stay out of the hospital?
Right.
And they were a funding source to keep people out of the hospital. Well, that's what the global budget is. A global budget allows a hospital to invest in different activities that will actually help their patients stay healthier, and it actually provides a financial incentive.
Yeah, I think one of the keys here is that what it does is it allows the hospital to evolve away from just being an environment in which the hospital makes its money on the volume of services it provides. So then the incentive is to provide services that are quote unquote profitable, so that they can then support the other kinds of medicine that they want to do. Whereas what this does is it gives the hospital some cost certainty, and then allows them to think about, well, what is good medicine for this community, and how can we treat this population in a way that one allows them to be healthy, as opposed to just trying to figure out, well, can I corner the market on heart surgeries, or can I corner the market on different types of treatment that would yield a high profit or high margin. So this is, I think it's potentially can be a real win for hospitals in terms of helping them really push forward the practice of medicine in their community.
And I think that is extremely well put. And I've seen in talking to hospitals around the country the particular interest among hospitals that are facing a lot of financial stress, and are really hitting that pressure between realizing that pushing volume more and more and more and more really isn't that great for their community.
Right.
And yet they feel pushed to do it because of the financial situation they're in, particularly rural hospitals that may be financially stressed and
Right.
really are worried about keeping the beds filled. This may be an alternative way for them to feel a lot better about what they're doing, because
Right.
they can be paid and then sit around a table and say, well, what will it take to keep our community healthier? Let's go to the next slide here. Whoop. So just a quick note on why Maryland did this first. As you've heard, if you've seen the other webcasts, all of Maryland hospitals are on global budgets now. And this comes out of a long history of rate setting in Maryland, more than 40 years. For a long time, we've had an independent commission in the state that set rates that hospitals paid. There's also been a history of collaboration among the hospitals related to rate setting and other things. Rate setting allows a relatively easy path to global
Right.
budgets. And the way I think about that is, if Darrell, you're the rate setting commission and I'm one of the hospitals, and we agree that my budget's going to be $100, you might say to me, how many admissions do you think you'll have? And I say 10.
Right.
And so you set my rate at $10 per admission. But if I start to have more admissions, then you start to lower the rate on me. And if I start to have less, you can allow the rate to go up. And in the end, I still get that $100. And in the end, it turns out to be independent of the number of admissions I have, because the price has been changed in order to hit that budget. So it's quite feasible to do in a rate setting system like Maryland. That's one of the reasons that Maryland's first. I also think that Maryland has a lot of ability, because of rate setting, to track what's going on,
Right.
because the hospitals submit all their bills on a regular basis. We have a terrific health information exchange in the state.
Absolutely.
And we did have terrific leadership at the hospital level, in the governor's office, in the General Assembly, to be able to get to a full state on global budgeting.
And I can't emphasize more the importance of being able to actually see what's happening in real time with care in a particular community. And because Maryland has this information system, and they've invested in the information technology, we have the EHRs set up so that we can get real-time information about how people are receiving care in their communities. And really, because in order for this to really work, both in rural and in urban areas, you have to be able to figure out who's doing what, when, and be able to be responsive when you think that people are not providing the kind of care that they need to provide in their communities. And then at the same time also be able to reward hospitals when they are doing the things that they need to do in order to help their patients receive care. And so having that information system, the EHRs, the EMRs, so that you can really monitor the care is just really key to trying to make this kind of thing work.
I think that's a great point, and particularly the ability to see data over a population of patients, even if it's from multiple EMR systems. It provides the tools for hospitals to succeed, as well as some good tools for oversight.
That's right. Absolutely.
So let's proceed here. Get this to work. So what we would like to do is provide 6 questions for hospitals and community members to ask to see whether global budgeting might be right, and then 6 steps to go from the world of fee-for-service across to the world of global budgeting. So let's start with the 6 questions here. So the first question is, what are the limitations to fee-for-service medicine for your hospital and community? Both financial limitations and health limitations. And the reason we put this question down, if everybody thinks everything's going well, it's probably not going to be the moment to totally throw everything up in the air and try a completely different system. But in Maryland, for example, we saw that there were some serious financial challenges, a lot of financial stress associated with fee-for-service, and a lot of health stress, and that we weren't able to invest in the kinds of programs that would address disparities, promote health equity, improve care, and improve community health.
And I think in a real sense, what the fee-for-service system does is there are kinds of care that you want to provide your community that's not directly billable. So so if you need to send a set of community health workers into a community to just do education, health promotion, those kinds of things, those things may not be billable to your payer. And so you do them, they keep the patients from being in the emergency room, from going to the hospital, you avoid the surgery down the line, and you made the investment, but then you don't get to recoup any of the benefit from making that investment.
Yeah, and actually I just recently met with someone who said she was on vacation in rural Maryland, and she overheard a discussion between an obstetrician and a friend saying how much they liked the new system in Maryland because it allowed them to deploy people around the community to help with high-risk pregnancies in people's homes. She said, I've always wanted to do that. Now we're able to pay for it. It's sort of the flip side of that. Second question, and third question, I guess, what are the opportunities in your community to prevent admissions? And such opportunities could be with care coordination, alignment with primary care, or community partnerships. If you're moving to a global budget, there is a real opportunity for a hospital to make savings. If it's for-profit, to make profit. If it's non-profit, to make margin. And that opportunity is in preventing admissions. Because if you're paid a global budget and you prevent admissions, you keep the difference on the back end. And we had, and so it's real important to think, well, what would we do if we had that incentive? What kind of work would we do with our physician community, our public community, as well as within the hospital to promote better coordination? You know, in one part of Maryland, for example, the hospital took over the school health program. And I asked, why did you do that to the CEO? He'd never had a hospital take over a school health program. And the CEO said, because we were looking at our ER data and we saw all these kids with asthma, which was preventable, and we thought we could run the school health program, which had like 75 staff, 23,000 kids. We could run that at break even and make money on the back end,
Right.
and that was an opportunity for us under a global budget. So look around and ask, where are those opportunities?
Mm-hmm.
The third question is, how is your hospital moving to value-based medicine? Is that a discussion that's even going on? And
Right.
so there are a lot of programs available outside Maryland besides global budgets. There are accountable care organizations.
Right.
Some hospitals participate in managed care plans for Medicaid or
Right,
Medicare
there's
Advantage.
the hospital readmission reduction program. I mean, if you're seeing Medicare patients, you have to be thinking about value, because CMS is going to move a lot of its payment over to value-based payment, and so if you're not thinking about value, you should start thinking about it, because it's coming, and in a real sense, I think it's where we should be thinking about medicine being 5 years from now, 10 years from now, and not necessarily paying for the volume of care which we're providing, but the value of care that you're bringing to the community, and doing it in a way that's smart and really is good medicine.
And so a hospital that's starting to think like this could bring in its ACO team and its medical home team and say, okay, could we really go to scale?
Right.
I met a lot of people who say, like, look, all these different CMS programs are great, but it only really covers a percentage of our admissions.
Right.
And it's hard for us to really change our process if we're going to be losing money on 70% of the patients to make money on 30% that are value-based. But it is a starting point. And
Right.
if you have people in your system who are already thinking about how to change things around to prevent admissions, then they're naturally part of the team here. Number 4, are you prepared to engage with payers to discuss innovative approaches to creating a
Right.
global budget? So this is a tricky one, because unlike, a lot of things maybe where there's a really clear path, global budgeting, especially outside Maryland, there's no clear path. And,
Right.
and people are going to have to be thinking about it, both on the public side and the private side. For the private side, how do you shift off fee-for-service? We'll talk about some of the mechanisms for that.
Right.
And similarly, you've got Medicare and Medicaid, which are not small payers. And we do think there are opportunities, but a hospital and a community have to be very prepared to engage. This is not something that the hospital does entirely by itself.
Right, and so maybe what you should do is think about, for each of your payers, what has been the growth in revenue for that particular payer over time, and then think about whether there are opportunities to sort of talk with that particular insurer and negotiate a particular rate of increase in order to take care of the patients in which you're seeing. And the other thing I think here is that if you know that the patient population in which you're serving from that payer is relatively stable, then that tells you that there's an opportunity there to think about doing some moving to a global budget.
Great. And then the next one is, are your physicians ready for a change? Now, David and I are physicians. I think you have a PhD, is that right?
Yeah, I'm
You're a doctor, but not a physician.
I'm an economist.
So, physicians are not known for their readiness to change, and some are, but not all. And I think that one of the things that was helpful in Maryland is that we had a very active physician community that felt like fee-for-service hospital medicine really wasn't a great thing for the physician community, in part because the hospitals were purchasing physician practices, and in the end, the physicians were quite supportive of the switch, and they saw also the opportunity to be leaders in parts of the value-based system.
Right.
I think that one of the themes that's emerging from these questions is that it really does require a hospital to think beyond to the payers, to the physicians, and to others about how to get this work. The last question is also very important. Can you explain how this will help patients?
Yeah.
It's not obvious necessarily on the first pass that fee-for-service medicine doesn't perfectly serve patient needs.
Right.
But you take a step back and you look at fee-for-service medicine, and patients get lost if there's not good care coordination. People get unnecessary tests. They may get unnecessary surgeries, and they certainly don't get the services needed to stay healthy. But
Right.
as you're thinking about it, it got to work at more than just the community health level.
Right.
It's got to work for each individual patient. They've got to feel like the hospital is changing to be proactive and to keep them healthy.
I think where patients will probably be skeptical is that if they have some type of event where they're going to have a large expenditure, and being nervous that the hospital will be concerned about taking them, given that they're going to be very expensive, and how that's going to impact on the hospital's budget. And I think there, having those protections where, one, we can see this in real time, we can adjust the rates accordingly. So we know that you have the major trauma patient that had the very expensive surgeries, and so that patients will get a sense that, yes, my hospital is going to be able to take care of me. No, they're not going to bump up against this budget at the end of the year and decide that they can balk, because there are things built into the contract between the hospital and the payer that allows for these kinds of
Right.
things to happen.
And also on a more concrete level, we heard in the last webcast, Leslie Simmons, the CEO of Carroll Hospital, said, we now make sure patients leave the hospital with medicine in their hands, not just a prescription.
Right.
We have case managers to help patients 24/7 now in our ER. So there are actual things that will change the experience for patients for the better. And,
Right.
you know, this is not a transition that should be discussed as a secret strategy. It's
Right,
something that is
right.
really important to engage with people. And we've certainly found in Maryland, working with consumer groups, having a consumer advisory board, engaging patients, that people really understand that it's an advantage for the hospital to be proactive and helping keep them healthy. So do you want to maybe pause for a second, David, if you want to give the email address again in case?
Sure, it's a globalbudget@ghU.edu, and the questions will come right here onto my iPad. I'll be able to direct them to Josh and to Darrell anytime.
Great. So moving on, we're almost done. Just a quick note that the average Medicare enrollee has 2 primary care physician visits, 5 specialists, 4 different sites of care, I think, in a year. They're all over. And so figuring out a way for the whole healthcare system to come together to support them is of interest to them. It can be of interest to them, and I think it's quite possible for global budgets to help facilitate that. So let's move on to the 6 steps to a global budget. If you haven't already decided by the questions that this isn't for you, and that you're still curious about global budgets, what would it actually take to get there? So first, it's very important to develop a compelling rationale for the hospital using your own data about budgetary trends and what would be done to prevent admissions. Basically, the compelling rationale is we're seeing some clouds on the horizon for fee-for-service medicine, which a lot of hospitals are seeing, and that probably is a relatively easy case to make. But also, if we could switch the incentives, if we could flip the incentives, suddenly we'd be able to do better financially by preventing admissions and really be able to tell that compelling story. I think that is the basis at every meeting for why a hospital wants to do this. We want the incentives aligned to be able to do better financially as we keep our community more healthy.
Right. And I think on expanding a little bit more on these preventable admissions, I think it's not only looking at sort of these ambulatory care sensitive conditions, but also looking at surgeries for heart conditions, hips, knees, things in which if the hospitals were more proactive in the community, they could improve the health of the population So I'm sure that most people in the community would much rather not have bypass surgery than have bypass surgery. And so if the hospital can help me figure out how to eat better, how to exercise, how to do things so that my arteries aren't clogged, they won't see me in the OR, but I want the hospital to be rewarded for that kind of outreach. And so comparing your rates of procedures to rates nationally and seeing where you're high, exceptionally high, those may be opportunities to try to do something in your community and take the savings that you get from global budgeting to improve health in the community in which you're serving.
Great. Let's go into the second step, which is to create a plan on how you would use a global budget to achieve better health at lower costs.
Yeah.
So you got the rationale, you have a plan. Here, if we had a global budget, this is the kind of thing we do. It doesn't have to be down to the dotted I and crossed T, but we would develop a program to reduce all these preventable asthma admissions. We'd work with the schools. Here are some areas, we would make sure that all of our frequent utilizers had case managers and a strong primary care home, all those things. Laying that out, that's going to convince people, because what payers are a little skeptical of is, are we just going to be paying for a global budget, but maybe the patients will go elsewhere, and we'll have to pay for their health care and pay for the global budget, and we'll get to that a little bit more. But part of overcoming that objection is to show that the hospitals will be ready to do the right thing.
Right. And the other thing is not only having the plan, but now we have the capability to actually see these processes, these different processes of care, and so that you not only can say that you're sending these community health workers out, and that you're doing these good things in your community, working with the school, but then we can see where if the kids in the school are actually using, if not your ER, someone else's ER, and
So
that sort of makes these plans really come to life in that
right. So you'd be sitting down saying, we will be monitoring these things,
right,
even as we're doing the right thing to achieve progress. The third is to start to engage payers, including public and private payers. There is a very important role for Medicaid for two reasons. First, Medicaid's an important payer for in states, and there's going to be a percentage of a lot of hospitals' admissions.
Right.
The second reason is that Medicaid is administered at the state level, and in order to get the waiver for Medicare to participate, the state is probably going to have to be supportive.
Right.
So Medicaid is like a 2-for-1. You get Medicaid, and hopefully you get the state support to bring in Medicare too. Medicaid has a lot of reason to want a stable, predictable, and aligned hospital revenue system. They want. They don't want to see. Oftentimes, people on Medicaid, because they have chronic health conditions, are quite expensive and are coming back to the hospital again and again. And Medicaid has a big interest, ultimately, in better management of those diseases rather than just paying for hospital admission and hospital admission. And putting the hospital's incentives aligned with Medicaid's incentives is something that a global budget does. So, hi, I'm calling, I'm just thinking about global budgets, I saw this webinar, we'd like to talk it over. That's a place to start.
Yeah, and especially in those states where the Medicaid population has been expanded, because then you're going to get a much more stable population that you're trying to care for, because the enrollment will be much more stable. And the episodes of care will be much more rational, because these will be people who have access to primary care as well as access to the hospital.
Great. Number 4, discuss with the other hospitals in your community. We talked before a little bit that a hospital really can't think of this totally in isolation. You have to think about the community, the payers, patients, but it's also the other hospitals.
Right.
And in Maryland, we had this advantage that, there is certainly hospital competition in Maryland, but everybody was working together with respect to the rate setting system. It's important because it helps. The more hospitals in a market go to global budget, the more compelling cases there's
Right.
going to be. If you have one hospital and across the street another hospital, one's on global budget and one's on fee-for-service, the payers
Right.
are naturally going to wonder whether just all the hospitals, all the patients will migrate,
Right.
from one to the other. And you could almost imagine the red carpet being rolled out, and that would be not achieving the goals that people want.
Right.
So, oftentimes more than one hospital is struggling in a market, and they could actually get together and say, we're in this sort of battle royale, and it's not helping either of us. We're both
Right.
buying equipment maybe we both don't need, and let's take a step back and look at whether a shift in this market to global budget could actually help both of us. And what we found in Maryland is that there are things that the hospitals come together on that really, are like a rising tide.
Right, right. I'm just sort of thinking, at some point they're going to have to think about what the Federal Trade Commission and the Justice Department is going to think about hospitals talking. Once you start talking about price, and the notion of price fixing becomes an issue.
Right.
And so I don't know exactly how the hospital gets around this, in the sense that I think when it comes to talking about quality of care, coordination of care, those kinds of things, that we're on real safe ground. And then when it begins to talk about, well, what are we going to charge for this service? Then we're on that third rail.
Sure, but we're not exactly talking about that, and
Right.
we're two doctors and an economist here,
Right,
so
right,
we're not
right.
no lawyers. But I would
Right,
say that
right.
in this case, that shift to a global budget is a leap.
Right,
And it
right.
requires a review by CMS.
Right.
It requires a special waiver. But certainly this may be another reason to engage the state relatively early, because they could probably provide an umbrella for people to have whatever discussions they need to think about what could be done.
Absolutely, absolutely.
The next step would be to design a mechanism to establish a global budget, and this is probably the trickiest part, and we're going to get to that, I think, in one other slide. So I will put that off for now.
Okay.
And then the last part, you've got a mechanism. You've got the other hospitals, if you need them, on board. The payers are interested in participating. Then you've got to work with your state and develop a plan for CMS, because Medicare has a payment system that's fee-for-service.
Right.
And to shift off of that to a global payment will require probably some kind of waiver. And it's great that on one of David's webcasts, he's going to have Dr. Conway, who is the head of the Innovation Center, coming to talk about this. So
Right.
that should be very interesting. But certainly, once you've gotten steps 1 to 5, you're in a position to make a compelling case for a special waiver under
Right.
the Innovation Center's authority. So let's talk a little bit more about the mechanisms. And there are two that we would highlight. One of them we're calling hospital level rate adjustments. And this would basically involve a hospital negotiating a global budget based on some less than expected increase in total revenue. So, look, we're on this 5% a year growth, and you say to the payers, we'll keep it at 4%, but we want that guaranteed. That would be an example. You get that amount of money, and then you start with your negotiated fee-for-service rate. So everything looks basically the same.
Right.
But over the course of the year, you have a commitment that they will pay changes in the rates that are adjusted based on whether the volumes are coming in as expected. And if they are, again, if there are fewer admissions, the rates get to go up, and the payers have now committed to keep paying them,
Right.
and vice versa. If the volumes are going up, the rates go down. And the hospital might consider engaging with a third party to certify the revenue and to do the rate adjustment in a way that could give confidence to the payers.
Right.
One of the advantages of this approach is that each admission just gets paid by itself. So if I'm admitted to Darrell's hospital in March and the rate for an appendectomy is $1,000 that day, that's what it is. Then maybe quarterly there's an adjustment. My brother gets admitted 3 months later, that rate
Right.
might be 1,100 because the hospital is doing such a great job reducing
Right.
preventable admissions. But you have a third party that would certify the revenue and adjust the rates, and everyone would be paid based on the rate at that time. The second possible mechanism would involve more of a reconciliation. A hospital might negotiate a separate global budget for Medicare, for Medicaid, and maybe for all private insurers. And you would have a reconciliation process at the end of the year. So you would still bill fee-for-service during the year, or your usual way. And then at the
Right,
end,
right.
you'd sit down with Medicaid and say, look, we had a negotiated $50 million budget, but it turned out we only did $45 million in services because we've been out there preventing admissions.
Right.
And Medicare would Medicaid would write a check for the difference of $5 million.
Right.
And part of the advantage of that is then if Medicaid had all these managed care organizations to deal with, it would be up to the Medicaid program to figure out how to apportion that $5 million. The hospital wouldn't have to do this complex mechanism of adjusting its rates.
Right.
It would be up to the Medicaid program. And similarly, Medicare would handle that for the Medicare Advantage plans, and perhaps the private insurers through an association could get together and work it out. If you looked at the privately insured block
Right.
of a global budget, well, there were market shifts between the different insurers. Let the private insurers work out the overage or underage.
So in terms of if I was the hospital administrator, the one thing that I would be concerned about is which one of these types of plans are administratively simple and not costly to actually implement. And so I'm sort of looking at the hospital level rate adjustment and wondering, well, is it costly for me to keep monitoring my price? And so the price of the appendectomy today is $1,000.
Right.
Next month it's $900. And when I'm doing my reconciliations, or do I have to then keep track of what was the price that day, and did I get paid for the service, or would I rather have a sort of a withhold or a bonus at the end of the year that says this is what we did this year, these were the prices that were set, and then sit down with the payer at the end of the year and just review, and then either I get the bonus or they take the withhold.
Right.
And I think depending upon the hospital, it's the circumstance in its marketplace. It'll depend and the maturity of their electronic record system in terms of how they're able to track patients and the kind of staff that they want to pay in order to monitor this. But so there's not. I don't know if there's one way of doing it. There are probably multiple ways of doing it. But I think this is the time and that we should be thinking about how we can be creative in trying to set these things up. And we may find that there's a real smart way to do it administratively. A year from now, 2 years from now, that there's a dominant way to doing it. But I would imagine that there are several ways of doing it, depending upon the market conditions.
Yeah.
You should choose one or the other.
And the other thing is, over time, I think this would be a good question for CMS. They may prefer one or the other.
Right.
And ultimately, CMS might provide some guidance on the best way to structure something like this. But I think your point is very well taken. That first approach is more complex for the hospital, but might be easier in some respects for the payers. The second is easier for the hospital, but maybe more complex for the payers. And I think that's one of the unresolved questions. But either of them are doable. And
Right.
you'd say, well, it's complicated. Healthcare is complicated.
Right,
And
right.
there's probably no simple way to reform a whole hospital's finances. But there's a simplicity once you get this set up, because the incentives are all aligned, and you're not doing this for some of your patients and 12 other things for all the other patients. It's
Right.
one thing. You just have to do this once, and it really helps with all the various other moving parts of the system. I think that may be it. Okay, we have, I think, one last slide. I think it's important over time for the hospital to show that it's not just losing market share.
Right.
You know, I mean, that this will be monitored, and it's particularly the non-preventable market share, that if people are just preferring other hospitals now, it looks like you're doing great because your admissions are going down,
Right.
but really the patients are going elsewhere. That's really the key test. So that's why hospitals need to go out there and prevent admissions, and that can be tracked through different systems. So it'll have to be, that'll be the kind of consideration that payers have. We already touched on the value of health information exchange in Maryland and elsewhere, and the ability to collaborate between hospitals. And Darrell, you talked about the potential to think outside the walls,
Right.
engaging with communities and addressing social determinants of health.
Right.
One last point I'd like to make before we go to questions is there's a different perspective on community benefits that this kind of financing entails. Community benefits are directly aligned to the financial interests of the hospital under a global budget. And one of the things that we've seen in Maryland is that the community benefits gets drawn in to the more strategic discussions. It's still, complete community benefits,
Right.
but it can be an incredibly important piece of the puzzle as you're trying to figure out, for the homeless population or for individuals with certain chronic conditions with different social needs. It would really help if they had X, Y, or Z social resource. Well, that would be something that community benefits could take care of. And you go from sort of the health fair kind of traditional community benefits to
Right,
something that's
right.
really aligned with improving health and reducing cost. I think that concludes
Well,
our
perfect. We have
slides.
some questions coming in. It's a kind of a two-parter that came in. It's a little complicated. It said they admire your leadership as, during as secretary. And so the question is, how much support is required at the state level to make this happen? Are there some threshold issues that have to be met in order to be able to put global budgeting, or if not, then what kind of private measures could the private hospitals initiate?
I think that it is very important for the state to be supportive, because ultimately this innovation model waiver really has to be granted to this, I think, at the state level. At least right now. I think that's a good question for Dr. Conway, but I think right now that's what I would assume. And it's also important because you need Medicaid participation, really, for it to work. And so I think that it's important to engage with the state. If the state's not interested, maybe it's sort of like prepare the folder for one day the state might become interested, because things have to change
So
at
that's
the
a
state
threshold.
level. I think it's important, but I wouldn't view it as like, on or off, binary. I mean, states can be, it may be that it's worth learning together with the state about this, rather than just assuming that someone's going to say no at the beginning, but also having a dialogue, because I wouldn't say it was so easy for people in Maryland to get to the idea of global budgets, but it certainly turned out to be the best option available to the state. And if you start talking about it, then over time it can turn into the best option if the cards fall that way.
And I think plus what piloting the program in the rural hospitals that we did pilot the program in sort of helped build the case that we could actually do this
That's
on
a
a statewide.
Yes, that's a great point. It doesn't have to be statewide all at once. I mean, and there will always be a range of interest at the state level on any topic, but particularly on something like this. But what might really engage the state is, if the hospitals got together and say, this is our best chance to save some critical rural hospitals, then the state really should be responsive to that and at least engage in the conversation and start there. It doesn't require the state to want to have to do it everywhere right at the beginning, I think.
So you can start with as you said, rural as a pilot.
As a pilot. Yeah, the other place I would think that you could start is you could start with a safety net institution that's taking care of a large percentage of a Medicaid population that you can really track and see where their care is being provided. I mean, I'm thinking of an example of a hospital that is in Jacksonville, Florida, had a relationship with the Medicaid office in Florida, where they took care of maybe 60-70% of the patients in the community, and they provided some services to the chronically ill patients in their community really helping the doctors that were taking care of them, adjusting their medications if they were on medication. And I walked into this hospital and was looking around in the emergency room, and I'm used to going into a safety net hospital and seeing the emergency room filled. And in this hospital, the emergency room was empty. And the reason it was empty was because the hospital had taken the care and moved it outside into the community, preventing those admissions. And because they had 70% of the patients, the state rewarded that by paying them for it.
So you're talking about, so instead of a defined geographic area, now talking about a defined population as a way of getting started.
Right.
Terrific.
That's great.
Had another question in terms of you mentioned, Darrell, about the real-time information about flow of patients, and Leslie Simmons mentioned that last time too, about the information from Chris. Are there some threshold issues around a baseline of IT in order to make this work across hospitals, or not?
Well, I would think that the thing that you're trying to prevent is you want to be able to catch bad behavior, in the sense that people who are not caring for, hospitals not caring for its population, and as a result they're going across the street to the other hospital, and so you just move volume from one place to another place, and you're not really impacting the care or the health of the community. So the way in which you do that is you have to be able to see it, in the sense that you have to be able to see that volume is going down in the hospital that has the global budget, and you also have to be able to see that volume's not going up in the hospital across the street. And so to that extent, you need to have access in fairly real time the utilization that's occurring for patients in the area in which the hospital is located.
And that's really to do the right oversight.
Right.
And then there's the question from the hospital's perspective: what data do you need to be able to succeed under the model? And some of that, probably should be real time. And in Maryland, we use these ADT feeds, which are generated when people register.
Audience may not all know what ADT stands for.
Yeah, ADT, or Admission Discharge Transfer. It's sort of the message that the registration system generates when someone is registering. We copy those, and real-time notifications can go to primary care doctors who have signed up for notifications on behalf of particular patients. And as a result, literally when someone's still in the emergency room, their doctor may be getting notified that their patient is there.
Right.
It's you can also use those to see who is going to the hospital most frequently, to communicate between hospitals when there are readmissions. And so I think there's a certain element of IT that is helpful for hospitals to see where they have room to move on the preventable admission side, and then to actually get information flowing to help the healthcare system actually prevent those admissions.
Well, it came up I'll sort of rephrase the question, but it came up, that slide that showed the utilization of the average Medicare enrollee and patients going from different delivery systems. So again, is that a threshold kind of thing in terms of having that information available in order for a hospital, a single hospital or a small group of hospitals, to move forward with global budget?
So if it's a rural hospital that's totally by itself, it's probably less important.
Right.
I think that if there's several hospitals working together, having some ability to exchange information is probably a threshold.
And have you seen places, how can they get started with something like that?
Well, there are health information exchanges in different parts of the country, and one of the things, ironically, holding them back is that when hospitals are in a hyper-competitive position, or they're, all paid fee-for-service, they may not be so excited about sharing data, but you switch that, and you start to have a conversation about global budgets. You say, well, I certainly want to know if one of the patients is bouncing back and forth, because we would want to work together to keep that patient healthier. And that's what's going on in Maryland.
Yeah, when I was looking at that data about the number of primary care physicians and the number of specialists, and it just made me think that I'm not sure whether all the providers are cognizant of how many providers their patients are seeing. And so what this does is it allows that information to come to light, and we can see whether we have a continuity of care problem, a fragmentation of care problem, and allow the providers to share information so that they can better take care of the patient.
Another question is how have the physicians in this first year, how have the physicians felt about the program? Any word about that and in the future?
Sure. I think that it's mixed, in part because in Maryland, the professional fees are still paid largely fee for service. So we have a bit of a tension between the hospitals being paid on global budgets and the physicians not always being paid on global budgets. Mm-hmm. And I think that one of the key priorities for the system in Maryland is try to resolve that tension. Mm-hmm. I think that the primary care doctors in general are more positive because suddenly the hospitals are coming to them and saying, what would it take for you to be able to take patients after discharge quickly, and really trying to bring them into the family and have a team effort to care for the patients. But I think that the particularly the procedure-based physicians are still wondering how their incentives get engaged with what's happening in the state. And I do think that that's one of the questions out there is the relationship with physicians. This is not to say that it can't work for all types of physicians, and I think ultimately the strains in the system are very threatening to the whole enterprise, including physicians. But I do think that having a strategy and having engaged physicians is pretty important. One of the first things that some of the hospitals in Maryland have done is bring in the physician community and figure out ways to work with them.
Yeah, I would think that you'd have to be able to answer two questions. One, how is this going to affect my practice and my ability to take care of my patients? And then two, how is this going to affect my income, my revenue stream? And so I think as a hospital moves forward to try to do this, they have to meet with the physicians who are practicing in their community, who are admitting patients to their hospital, and talk to them about, one, that we think that this is going to help us get to a place where they can practice good medicine, and in terms of the kind of medicine they want to practice, we can get alignment. And then the issue then becomes, what type of financial relationship does the hospital need to have with its physicians, or what type of financial relationship does the payer need to have with the physicians in order to align the financial incentives?
Well, a comment about the physicians highlights another question that came through in terms of, you had mentioned ACOs, patient-centered medical homes, Medicare Advantage. Are there any of those things helpful in terms of moving towards global budget in the other neighborhoods outside of Maryland? Well,
we did say one of the questions to ask was how the hospital is thinking about those things, and a global budget is compatible with those. It really aligns the incentives of the hospital with those. So if you have a medical home that's based outside the hospital, you have a natural tension with a fee-for-service hospital. The medical home's trying to prevent the admission, the hospital needs the admission, and it's that's not a really productive tension, really. If you have a hospital with a global budget, then its incentives are really aligned with the medical home. And so I think that you can, if done well, it can really point everybody in the same direction. I think it's a great question to ask John Chassar, who's coming next week, because he's been very involved in the ACO community in Maryland, and I think we'll have a perspective on that, as well as Jonathan Blum, who designed many of those initiatives when he was at Medicare and is now at Care First, the insurer.
Any comments about that point of view in terms of structures that might leverage for
I think Josh is right in the sense that these structures are trying to give incentives to particular providers to provide care and prevent hospitalizations. And outside of giving the hospitals and the communities the same incentives, we get this sort of misalignment. So I think that this, under sort of a global budgeting mechanism, that if you're doing an ACO, or or even if you're working right now with regard to bundle payment, you're on your way to doing the kinds of things you need to do in order to implement a global budget.
And the last question is, you mentioned some of the community resources that might be available. Are there some key ones that if a hospital wanted to think about this and approaching the state or approaching other payers that they want to line up?
It is a tremendous opportunity, global budget, to bring hospitals and communities together. And it will depend a bit on the particular challenge that's there. But I think when hospitals start looking around outside the walls, they'll see a lot of people very excited to work with them. That's been the experience in Maryland, and if it's the school system for kids with asthma, it could be the aging services system for preventable admissions for older adults. It could be the homeless services for individuals with homelessness who are coming back and forth.
FQHCs,
right?
And even
We can talk about the
the health department in terms of the things in which the services that they're providing to try to help keep people healthy.
Sure. We have at one hospital in Western Maryland where there is literally a bridge between the hospital and the health department, and they say they've been going back and forth across the bridge a lot more now that they're on the global budget and thinking about different types of programs, smoking, behavioral health, huge opportunity for coordination with providers, because as we heard before, a lot of the patient in the last webcast, a lot of the patients who keep coming back to the hospital with preventable conditions have serious mental health or substance use disorder issues. So I don't think there's going to be a shortage. I think it's an embarrassment of riches in a sense, about all the different services that are out there that would really love to work with the hospital. I think that will be, and maybe daunting for a hospital team that hasn't really done a lot of communicating like that. But I think it would be a fun part of the job, because you'd ask people, hey, what would you think it would take to reduce admissions? And people will have different ideas, and you'll get to work with them and pick.
That's terrific. I think that's a great segue to our fourth webinar, and we're running up near the end of the hour here, so please join me in thanking both Josh and Darrell for a very the hour's gone by very quickly, about how global budgeting might come to your neighborhood. As I mentioned at the beginning of the hour, the next webcast is going to be on global budgets across the healthcare continuum, and which dovetails very nicely with these comments about what other community agencies might be involved. We're going to have, as Josh has mentioned, 3 panelists. They'll be here in the studio next week. One is John Cheshire. He is the president and CEO of Greater Baltimore Medical Center, early pioneer in ACOs. The second participant will be Vincent DeMarco, and he is the president of Maryland Healthcare Alliance for All. And then the third is Jonathan Blum, and he is currently the EVP for Medical Affairs at Care First, which is the Maryland Blues, but he was formerly, as Josh mentioned, the director of CMS and designed many of the features of the waiver. The webcast is going to be live a week from this Friday, December 4th, from 1 to 2 o'clock. And in the interim, if you have any questions, please feel free to continue to send them to globalbudget@ghU.edu. And this webcast will be archived and be available in the middle of next week for further review. And again, thank you very much for joining us, and hope you have a happy Thanksgiving.